Hi, good evening. Good
Good
evening,
evening.
everyone.
We are live now, doctor.
Thank you, ma'am. A very good evening and a warm welcome to one and all. So here we have joined the webinar today for the YOSI Journal Club, and it is indeed my privilege to be the host for today along with Dr. Anujit. So without further ado, let me take the privilege of running you through what we have today. Is my screen visible?
Just give it a minute, Niranjan. It's just loading.
Yes.
Yes, it's visible now.
All right, thank you. So we have a very interesting topic for discussion and a star-studded lineup headed by the keynote speaker, Dr. Supriya ma'am. So before we jump directly into the event, I would like to take you through the journey that we've been through with YOSI Journal Club. So YOSI Journal Club was initiated with the theme of publish or perish to start with. So the team YOSI, headed by the most dynamic governing council, headed by the President Devakant sir, immediate past President Sonal Kalia ma'am, Vice President Karan sir, Secretary Nilesh sir, Treasurer Aditya sir, and Joint Sec Prasanna sir. So with this support of the governing council, the support of the executive team of YOSI in the term 24 to 26. So why was this journal club designed? So this was to cater to the various needs of different uh, PGs and beyond PGs, that is the young ophthalmologists and fellows, as to what is required at each and every stage of their career in the field of publishing. So the idea of starting the journal club was to address the various needs and necessities, starting from defining the problem, specifying the research question, and much more. So the ideal format that was structured and made standard for Journal Club was to have a presenter and a mentor, followed by moderator and panelists, research expert, and we have the privilege of having a keynote speaker for today as well. So we have a structure of IMRAD for designing a manuscript. We do have a structured way of doing it in the form of MARI. And the idea was to give it a step-by-step approach to reading and understanding medical evidence. So presenting to you the team YOSI Journal Club, headed by our in charge and the most dynamic joint secretary, Prasanna Venkateswara sir, and Dr. Sonia Kalia ma'am, who actually conceived the idea of Journal Club and initiated the whole process, followed by the members, myself, Dr. Anujit, Dr. Ayushi, Dr. Arshi, Dr. Karthikeyan, Dr. Rolika, and Dr. Samir. So here we really would like to encourage more participation from each and every one of you. So please feel free to contact us, email your interests to present or participate actively in the journal club. So started in 2021, Journal Club tried to address various aspects in ophthalmology, and we have tried to leave no topic untouched. And we've had a panel and an array of excellent experts and presenters from the subspecialties who contributed in several ways to making this whole journey a memorable and a successful one. And not only that, we've always been blessed and privileged to be collaborating with the Indian Journal of Ophthalmology under the able guidance of Dr. Vanati Madam, who's been so generous and benevolent to include us in this wonderful collaboration of IJOC Livewire. And we've had several episodes spanning over more than a year. And following that, we've had a very dedicated and an exclusive journal club for each and every subspecialty addressing a particular article with the standard prescribed format. So IJOC Livewire and the Journal Club has grown leaps and bounds since then. And we've managed to pull off an event every month catering to the various subspecialties in ophthalmology. And this is where we stand today, where the theme of today's topic or today's webinar is going to be the wonderful relationship between cataract and ARMD. And we have a very, very special keynote speaker today, Dr. Supriya Dabir Gautam ma'am, who is a very known personality and a stalwart in the field. And the topic for today by her is going to be update on retinal imaging. So I would like to introduce our keynote speaker for today. So, Dr. Supriya Dabir ma'am has done her PhD in high resolution retinal imaging from Maastricht University and awarded in 2024 Vitro-Retinal Fellowship from Aditya Jyot Eye Hospital, Mumbai. And she's done her master's in ophthalmology from St. John's Medical College, Bangalore. She currently heads the Department of Vitro-Retinal Sciences at Rajan Eye Care, Chennai, and has spearheaded the establishment of the Retina Department and Monetary Health Services, Chennai. She has several academic contributions, has been an invited speaker at multiple national and international conferences, excuse me, and has had active involvement in both postgraduate and PhD mentorship. She's been awarded with several accolades, and to name a few, the YKC Pandit Award by MOS, Maharashtra Ophthalmic Society, Dr. Bashir Mekri Award by Karnataka Ophthalmic Society, and Best Paper Awards by BOA and International Conference on Nanomedicine and Ophthalmic Research. And she has several publications and editorial work to her name. She's the co-editor of the very popular textbook of vitreoretinal diseases in surgery by JP, published multiple papers in index journals, and has contributed several chapters to Indian postgraduate ophthalmology textbooks, and is also actively involved in international clinical trials as well. It is indeed a privilege to have you with us today, ma'am. And we welcome you to share your screen and kindly present your keynote speech for today, ma'am.
Thank you, Niranjan, for the very kind introduction. I'd like to thank the whole YOSI team. This is, having a keynote address here makes me feel much older. And it's a privilege to be a part of this young organization today. So I'm going to be speaking more than an update. It's more like an evolution of the various retinal imaging modalities. I'm just trying to share my screen just a minute.
Yes, ma'am. Visible.
Yeah, thank you. So as I said, it's an update, but also an evolution, because it's always good to know where we've come from and where we are heading. So a little bit of the past is essential for this. That's what I'm going to be speaking about today. So we all know that this is the golden age of ophthalmology, because we are having such a revolutionary era right now, where all the advanced imaging technologies are reshaping ophthalmology, with helping us with diagnosis, with helping us improve prognosticate diseases, help us with the outcomes. And we are trying to make it minimally invasive. And also we all know how much machine learning, deep learning, and AI has a role to play in ophthalmology right now. So it couldn't have begun without the first use of the ophthalmoscope by Helmholtz and his team in 1850. This was the first time where they viewed the retina in living patients. From then on, it moved to fundus photographies, where you can see this huge machine which is occupying the entire table, and that's how big the fundus cameras used to be. Moving on to angiography, where they used to have those digital cameras and take one image and then wait and develop the images and see how the angiographies come. And imagine if the patient had blinked or there was some movement, then they would have had to redo the whole thing, and that wouldn't have been possible because it was an invasive modality. So the skill was so much more, but also there were a lot of these limitations to the modalities. And then comes in the modern fundus cameras that we have, which help us with a field of vision of almost 30 to 60 degrees, most of them being in the 50-55 range of field of vision. And today I'm going to just speak about the various, how from the regular fundus cameras, we've moved on to multimodal imaging, fundus autofluorescence, wide and ultra wide angle fundus imaging, pediatric imaging, oximetry, which is an add-on to the fundus camera, handheld fundus cameras, and smartphone cameras. So the various filters, it all began with the green filter, because this gives you so much more. You can see the images, the vasculature so much better, because the contrast is better, and the hemoglobin absorbs this green light too, the wavelength. So everything appears much darker. You can see the cotton wool spots. You can see the retinal nerve fiber infarcts. So these are much better seen in the different filters, like the green filter. Hence, every angiogram begins with a red-free or a green image. Fundus autofluorescence helps us detect the various the structures which have the property of autofluorescence. The property of autofluorescence in the retina, like you could have drusen, you could have areal dystrophy. So this is a patient with retinitis pigmentosa, where you can see the kind of ring that you have, the autofluorescent ring that you have, and this coordinates with the kind of vision, the field of vision, or if you do an ERG, this correlates with this is a small island, which is island of vision that the patient has in this whole sea of darkness. So that's where the photoreceptors are maintained. And this is a patient, you can see a hypofluorescent ring here. This is a patient of cone dystrophy. You can see this drusen, which could be at the macula or could be at the level of the optic nerve head itself. So these are various filters which are used. We also have the multicolor imaging, where you have the blue, the green, and the infrared reflectances. And you have basically, it gives you the depth perception. It gives you the various structures at the different depths within the retina. So blue is more for the superficial retina, the surface. The green filter is more for the inner retina, and the red is it's a longer wavelength, deeper penetration, and helps you more with the RP choroidal level. Similarly, here you can see the raised neovascularization at the disc, this raised front, vascular front, seen in the angiogram with diffuse leakage. And in the regular fundus photograph, not much of, 1 second. In the regular fundus photograph, you can't you can see the NVD, but it's not as clearly visible as in the multi-color imaging. Similarly, in this patient with BRVO, here you can see the hemorrhages, the cotton wool spots, but with the multicolor photograph, you can appreciate the area of occlusion much better. You can see the sclerosed vessels. In the green and the blue filters, you can see the area of infarction also here, and the amount of macular edema also seen in the filters. Moving on to the ultra wide imaging. Now, when we talk about wide, it's about 100 degrees. And when we say ultra wide, that's more than 100 degrees. Some of the cameras even claim 120 to 130 degrees field of vision. You can pick up large peripheral lesions like lattices, GRTs. You can see the extent of PRP done, whether in the periphery there's some amount of unlasered retina that you can tackle, because maybe this patient is going into NVG. Some amount of VEGF needs to be reduced in this patient, and hence this area can be lasered. All this is picked up by these wide field photographs. And when you look at the wide field imaging in terms of the fluorescein angiograms, this is a montage of where the previous, where just the normal camera detects. This is the area, the zone. And if you look at the wide field, it goes on almost till the ora. And you can pick up these peripheral non-perfused areas, the peripheral NVEs here leaking, and that can then be tackled in these patients, especially in patients with peripheral polyps, IPCV in the periphery. Simultaneous FFAS and an ICG can pick up the specific area that you can further do a focal laser to and resolve the polyp. Pediatrics plays a huge part where this ultra-wide imaging helps us, especially in our screening of ROP, retinopathy of prematurity. Here you can see how this patient, this baby, has a ridge here, a vascular ridge, stage 3, zone 2 posterior actually with pre-plus, and almost has a minimal amount of bleed in front of the fovea here. Just a minute. Yeah, and then post laser, you can capture the images. This also helps when a person is learning laser, or you can try and detect where the skip areas are, if there's some more laser that needs to be added. And it also helps to explain it to the parents that, see, this is the disease that the baby has, and this is what we've done, and this is what we are looking for, the kind of resolution. So they also feel reassured that the treatment is going along the right lines, and they do see visible change. And this is also very necessary for documentation, as the National Neonatal Foundation now requires. It's a prerequisite to document with photographs every baby that we see with ROP. And you can see how the scars are healing. While detecting ROP, while screening for ROP in these neonates, we've also picked up various other lesions like retinoblastoma in this baby, lipemia retinalis here, colobomas in some babies, and hence they can be treated much earlier on. Angiogram in these babies also helps detect the avascular retina. In some babies with ROP, though post laser, you don't see the kind of regression that you do expect, and you can find some skip areas that need to be lasered. Helps in Coats disease. You see telangiectasic vessels, the areas of non-perfusion, and you know exactly where to treat these babies, where the lesions to treat. Now, adding on to a fundus camera, just 2 digital cameras with different wavelengths can help you get an oximeter. Now, we all know post-COVID how oxygen saturation has been the flavor of the season at that time, but this came in much before that. And this is basically, the retinal vessels are the only vessels that you can see and detect the oxygen saturation in. This kind of reflects the way they say the eye is a window to the rest of the body. It also helps us to assess certain systemic conditions in the patient. So what it does is it basically has the 2 cameras which shine the different wavelengths of light, and you pick up the light in the center through the oxygenated blood, and the reflectance of the light intensity outside the vessels, and a ratio of this in the 2 wavelengths helps you detect the optical density ratio, which kind of is linearly related to the oxygen saturation. And what it gives you is a overlay map like this, a color saturation map. And here you can see that it's color coded in such a way that the hotter colors, red and orange, are a higher saturation, whereas the cooler colors, blue and purple, are the decreased saturation. This was a patient that we had with CRA, who had developed CRAO, and we did paracentesis. Now, in these patients, pre and post paracentesis, you can't really go ahead and do a FFA pre and post. So these non-invasive modalities like OCT angiography and oximetry really help us know whether paracentesis was done adequately and the kind of responses that you get immediately post-treatment. Here in this patient with BRVO, this is a patient with acute, whereas here you can see that, more of purples and blues here in the area where the occlusion is. And here, as recanalization is taken place and the oxygen balance is now deferred, you can see how there's compensation happening with the collaterals in the chronic case of BRVO. Also helps in certain diseases like glaucoma, and helps in patients. We've looked at it in the idea when we first had the oximeter way back in 2012, 2013 at Narayan Netralaya, was basically to see if we could even keep these in like malls or in OPDs, in general OPDs, take quick photographs of the retina and see, okay, this patient has less perfusion, maybe he has some systemic disease. So the point was to try and pick on systemic diseases and treat them earlier on. Lot of handheld fundus cameras have come in. This helps us with our telemedicine, going back to like outreach programs, going into the community and taking images, sending it back to the base hospital, and a doctor sitting there analyzing it. So it basically brings the masses closer to us. And this has been a boon, especially during the COVID times when a lot of patients couldn't come into our clinics. This has moved on to the smart fundoscopy apps are there onto which the photographs can be uploaded. And with AI algorithms already fed into the apps, it does help pick up those that need to be treated. So retinal photography has also helped diagnose a lot, not just ophthalmic, but also non-ophthalmic disorders. In fact, there are papers in which they even talk about the patient's IQ. Depending on the various parameters in the eye, like the arterial ratios, the architecture, the angle at which the artery or the vein bifurcates, those kind of the vein, the lumen versus the wall thickness, things like that. A lot of CNS disorders, cardiac disorders, hypertension, kidney disease, and as I said, even schizophrenia, things like that have been correlated with these fundus photographs. Moving on to the next modality is, am I good with time? Yeah. OCT and its variations. I'm going to talk about spectral domain OCT, how the various biomarkers have kind of given us a clue on how to treat our patients. Enhanced depth imaging, what it's added on, swept source OCT, on fast, handheld, microscopic integrated OCT, OCT angiography, and a little note on adaptive optics. So we've seen when OCT came in, the time domain OCT, Stratus was one of the earlier on OCTs. The kind of pixelated images, the kind of resolution that you had was way less. And what we have right now is almost near histology kind of imaging of the different layers of the retina. The international nomenclature has helped us form a consensus across the globe on what to call each structure, and helps us talk about it in an even tone across the globe. The different biomarkers also, like for example, in patients with diabetic macular edema, you can see these hyperreflective dots, some amount of subretinal fluid. We know that when you see these hyperreflective dots, which are basically the extravasated lipoproteins or the activated microglial cells, these may have a better response to intravitreal steroids. So you would want to treat the patient with intravitreal steroids. Patients with neurosensory detachment like this, you know that leaving some amount of SRF helps to have a protective impact on the photoreceptor. So you don't necessarily need to dry out this SRF completely, and they do respond well to steroids. Patients with septate like this, bridging retinal processes, these are basically the Mueller cells and the bipolar cells that transmit the information from the inner to the outer retina, and their presence is good. With chronic cystoid degeneration, when these septae break, the bridges break, that means it usually is a long-standing disease, and the prognosis may not be that great. Drill, which is the disorganization of the retinal layers. Here also it means long-standing damage, and usually if it's more than 500 microns, then the prognosis is not too great. Integrity of the ellipsoid zone, post-operative or pre and post-operative, when you explain it to the patients, when you have these defects, you know that the visual outcome post-surgery is not too great. But here you have a relatively more intact ellipsoid zone, or a photoreceptor ISOS zone that we used to say earlier on, has a better visual outcome. Similarly, here you can see the ERM with multiple folds and tractional schisis of the inner retina. And post-surgery, when the integrity is still maintained, these are the patients that do better in terms of visual outcome after surgery. So these are much easier to explain to the patients when you have these OCTs out in front of them. They help as biomarkers. They help you prognosticate the kind of visual outcomes that you can get post-surgery. In AMD, also seeing SHREM, or the subretinal hyperreflective material that you see, whether it's scarring or whether it's exudation, fluid, hemorrhage, All these help us explain to the patient and try and see how the response is to treatment. ORTs, outer retinal tubulations like this, a lot of people do confuse it for subretinal fluid, but when you have a nice ring like this and it's in the outer nuclear layer, then you do know that these are the tubular structures, which are basically the outer retinal cells. And this kind of denotes photoreceptor degeneration and could mean poor prognosis. Now, what is EDI? So initially, when the spectralis was in the clinics, we used to kind of play around with the machine and try and move the device closer to the eye so that the structures invert and you're able to see all the deeper structures come closer to zero delay. And what we get out of EDI or the enhanced depth imaging is basically better visualization of the choroid. But now in the newer modalities, in the newer machines, there's a button that you click on your regular spectral domain OCT and it goes into the enhanced depth imaging. Now, why do you need that? Because we know that a lot of diseases are related to a pachychoroidopathy. It's a spectrum of the pachychoroidal diseases, and hence understanding the choroidal vasculature kind of can help us understand these diseases better. It's also been classified into various structures, and for example, in CSR, you have the dilated outer. You can see these large choriocapillaries here, and in the attenuated inner layers. This is more indicative of CSCR, unlike VKH, which has the darkened type of pachychoroidopathy. Of course, there are other features in the OCT, like your undulating RPE and cells and septae, etc. But if you're just looking at the choroid, then there are kind of different forms of the pachychoroid that you could look at and see their response to treatment. This is a patient, you can measure how the pachychoroid, with calipers, you can measure how thick the choroid is, and post-treatment, how it is responding better, and the subretinal fluid also is decreasing accordingly. In patients with CSCR, it's not only the eye that is affected, but we've seen that the choroidal vascular index in the other eye also could be decreased. And then if you look at pre and post treatment also, it shows it's like a quantifiable index that you can look at as a response to treatment. So this was EDI with spectral domain OCT, but if you want better imaging of the choroid, then there's nothing like the swept source OCT, which is basically OCT with a longer wavelength, helping deeper penetration and avoiding the scattering by the RPE. And also they give us longer scans, so you get the optic nerve and the foveal pit in the same scan. So longer scans help in these patients with myopia. If you look at, this is a spectral domain OCT and this side is a swept source. You can see the kind of schisis that you can appreciate here in this myopic maculopathy, unlike the regular spectral domain OCT. Also helps look at diseases, as I said, pachychoroidal diseases, any disease of the choroid, CSCR, IPCV, any of these VKH and all, swept source OCT is the best way to go. On-fast OCT gives us basically it's complementary to what we are already doing with structural OCT. It basically reconstructs the on-fast images, and the software gives us like a topographical documentation of the different layers. And if you can see, this is a patient with CSR. You get these enlarged choroidal vessels in the area of CSCR. Here, when you look at this on-fast, this is basically above the RPE. This is at the level of the RP, and this is below the RP. You can see within the area of fluid, SRF, you can see the hyporeflective blebs here, which is basically the PED, and that's where you're getting the pooling of the dye in the angiograms also. Also helps us detect networks of polyps or the BVN in a lot of patients with IPCV, and you can follow them up to treatment. Bioptigen, a handheld OCT, is greatly useful in pediatric patients, in neonates. This is an image that we had done for a patient with retinoblastoma. You can see the tumors right next to the optic nerve. Helps us actually see if the tumor is involving the optic nerve. Of course, it is not exactly like an MRI or an optic nerve histology would be a better guide for the involvement of the optic nerve, but OCT does tell us where the tumor is encroaching into the canal. And here, post regression of the tumor, you can see how it is closing up. Different conditions in babies were picked up: astrocytic hamartomas, foveal hypoplasia, cone dystrophy. So then the parents can be guided on basically how the outcomes of vision are in these babies and how they need to be followed up. So when it was handheld from pediatric, we thought let's move to adults, and we did do it in intraoperatively, but that was a bit cumbersome because in a sterile, you have to move the microscope, bring on the OCT, and in a sterile environment, things can get a bit messy. This is a patient with an ERM, and immediately post peeling, you can see tenting of the peak of the fovea here because of the tractional element, and then slowly over time that reduces. Then came in the microscopic integrated OCT. This was a surgery that I performed in 2014 when it had just come in through Zeiss. And you can see these, it really helps you delineate where the membranes are. You kind of know the kind of adhesions, whether there's a gap there where you can go with your instrument in between that. So apart from if there are these second membranes that are left behind, those are the ones which can cause re-RD. So really helps you kind of pick on during surgery, find the areas of cleavage, and makes life much easier at the end of surgery also. These shadows were basically caused by the instruments as you go closer. Silicone instruments, of course, would be a better way to go ahead and not cause shadows. Moving on to the next modality where an add-on to the OCT is where in replacement, not replacement, but as an adjunct, and in some cases, maybe a replacement to a fundus fluorescein angiogram, is doing an OCT angiogram where we do it without the dye being used. Helps us to get segmentation of the retinal vessels, basically the plexus and the choriocapillaries. The superficial, deep, and the choriocapillaries are all seen clearly. A patient with CNVM here, you can see the leakage, but in an OCT angiography, because there is no dye, you don't see leakage. So how do you detect a pathology is you see this glomerular network here of vessels. Different morphologies have been described. This is a medusa head, this is a C fan, a glomerular network. So unlike type 1, type 2, which is or type 3 in structural OCT, OCTA has given a different morphology types, classifications. Now, how do you know whether it's active or quiet? So if you have a typically lacy wheel pattern with many capillaries, lot of anastomosis, arcading between the anastomosis and a halo around it, then you know it could probably be an active lesion. But if you have long vessels, like a dead tree appearance, not many anastomosis, large, fat, mature vessels, and you don't get this halo around. The halo is basically, it could be SRF or hemorrhage around the lesion. In absence of these could mean that it's a quiescent lesion. Now, where does this help us? We also know in some diseases like chronic CSR, you have so much of RP alteration. Even a regular fundus fluorescein angiogram may miss a neovascular occult CNVM here. And if you look at this OCTA, see, you don't really see the CNVM kind of complex here. But if you look at the OCTA, it confirms the presence of the CNVM. And you know, these are the cases that will really respond well to anti-VEGFs. Similarly, in this patient, FFA showing some mottling of hyperfluorescence here. ICG does show you the network here, but if you look at the OCTA, it's such a classic network here. Whereas your structural OCT just gave you some shallow irregular RP kind of picture with SRF. So here the presence of a network, a vascular membrane is confirmed, and they would respond well to anti-VEGFs. Similarly, so much of RP damage here, so many of these window defects, some amount of staining, all that is here. But if you do the OCTA, you see this beautiful network which then regresses with treatment. Similarly, neovascularizations picked up in diabetics and other retinal vascular diseases. This is NVD showing leakage on FFA. But if you look at the OCT, you get this beautiful frond of lacy network of vessels. NVE picked up very easily, FFA showing it. But if you look at the OCTA, also you see this network here. So in diabetes especially, it has played a huge role in our understanding of the foveal avascular zone. Different parameters like measurement of its circularity, perimetry, its radius. The larger it is, we know there's more ischemia in this patient, and how they respond to treatment post-repeat anti-VEGFs. We know if the deep capillary plexus is involved more, then the extent of disruption here, then their responsiveness to anti-VEGF may be limited depending on the extent of loss. This is a patient with CRAO that we did OCTA, and you can see how the superficial capillary plexus is not really showing any vasculature, any blood net, vascular network here. And immediately post paracentesis, we did the OCT angiography, and you can see how this vascular network is established. So helps us in certain diseases where you don't really want to do invasive tests, and you can't really do it immediately, repetitively in these patients. It has a lot of advantages, few disadvantages also, but now as we're using it more, we do realize its limitations and how we can get over them. Of course, you need good cooperative patients, you need clear medias, otherwise the kind of artifacts and the kind of segmentation issues that you can have will limit its use. Coming to the end of my talk is adaptive optics. What do we need adaptive optics for? Is basically we all the images that I've talked about, all the imaging that I've spoken about till now has been limited to the macroscopic scale, because the correction that was done by the cameras was only defocus, that is spherical correction. But when you bring down, you correct for astigmatism, you correct for higher order aberrations, then you're able to compensate and get better images. And this is almost to the microscopic scale. So this is a technology which was used by astrophysicists in their telescopes that we have now adapted onto the fundus cameras or SLO-based machines to try and see the structures of the retina at microscopic scale. So this is an SLO image where you have 15-20 micron kind of resolution. And with adaptive optics, you almost have 2 to 4 micron resolution, lateral resolution. So if you're looking at this, this is a mosaic of all the photoreceptors, the rods specifically here and the cones. Mainly the cones, because the cones are what reflect the light back and what is there in the center of the fovea, at the center of the macula. It also helps in certain, for example, this is an image of a patient with dry AMD, helps us diagnose whether it's pseudodrusen or drusen. Here you can see the collection is below the retina, below the RPE, whereas here in pseudodrusen, it is subretinal. Now you want to know which are the patients you'll follow closely and what the significance really is. So when you look at the cone count, the count of the photoreceptors above the area versus the normal area, you can see more damage is done in pseudodrusen because it's closer to the photoreceptors than those in which the involvement is below the RPE. Here, the photoreceptors are more or less maintained. So the patients with pseudodrusen need to be followed up closely. You can monitor the progress in patients with geographic atrophy, patients with various kind of inherited retinal disorders. And here you can see the movement of the various RP cells, the various macrophages here, and how even in a disease where you're kind of seeing that there's not much progress, if you look at it in a microscopic level, then you can assess progress, especially in various retinal disease, dystrophies. And it's very good to follow up these patients. Helps you even look at vasculature well, whether the wall, the lumen, the ratio between them, to try and pick on patients with hypertension, arteriolosclerosis, try and correlate it with their systemic CNS or their cardiac status, and see who are the patients that need to be followed up closely systemically. So this kind of cellular monitoring, also when you have treatments like gene therapy coming in, or we are talking about newer lasers, subthreshold lasers, yellow lasers, you want to see the efficacy of this treatment at cellular level. With structural OCT, you're still looking at it in macroscopic level of layers, but here you're trying and seeing the efficacy of these treatments at cellular level, and that's where adaptive optics will play a huge role to play. Artificial imaging in all this, we know the different kind of devices which have come in, where all it has helped us with detection of diseases, the inbuilt algorithms which certain devices have, whether it's fundus cameras, whether it's OCT, how the role it plays, especially in community diseases, whether it's ROP, diabetic retinopathy, helps try and streamline our workflow and reduces the burden onto our clinics. So the impact that it has made is early diagnosis, getting these subclinical changes, identifying them, trying and preventing, early intervention, seeing their response to treatment, safer, non-invasive tools, and helps in teleophthalmology, where you're trying to have remote diagnosis and triage patients that really need to come into care. Helps individualized treatment, where individual biomarkers tell us about the progression in that patient, the kind of frequency for follow-up, customize your treatment to that patient. Deep learning and AI has helped us kind of personalized treatment plans for that patient and reduces the variability in treatment responses. And as I said, imaging along with genetic profiling can certainly help in a lot of these inherited disorders. So basically, what we are moving towards is precision ophthalmology, where we can develop personalized evidence-based care, and this ultimately enhances outcomes and patient satisfaction. And that is what our retinal imaging is aimed towards. Thank you very much.
Thank you so much, madam. The wonderful paradox about today's topic is seeing the most recent advantages in the vintage black and white movie side. So thank you for taking us through this wonderful journey of retinal imaging and I'm sure no mode of imaging was left untouched. So thank you so much, ma'am, once again for having taken out time out of your busy schedule and been with us and enlightening us on this methods of retinal imaging. So I also request you to, if time permits, stay with us for the article presentation and if possible, share your valuable inputs, as again, that is curated to be an interaction between cataract and ARMD. So if time permits, please to join us for the rest of the webinar as well. And I would like to hand it over to my co-host, Dr. Anujit, to take it forward from here.
Oh, thank you so much, Niranjan, and thank you so much, ma'am. I think that is not yeah, collection of images is the wrong word. It's a constellation of excellent images, learning through example. Um, I think I learned the most over here because we tend to usually skip the advanced imaging techniques because in medical colleges and PG institutes, we are usually only focused on OCT and FFA. And then if we get the diagnosis, it's always rotate the patient for the next patient. But it's very nice to have a comprehensive look at all this. With that, we'll go on to the meat and butter of the webinar over here. So it gives me great pleasure to introduce the speaker for today, who's been presenting the article topic that has been described, Dr. Ritika Kanderwal, who is a junior resident first year at the Department of Ophthalmology at All India Institute, Kalyani. She completed her MBBS from GSVM Medical College in Kanpur, and now is a first year resident. She has also completed an internship from there, and it's very heartwarming to see such young residents coming up in YOSI, and I hope this will encourage more residents to go forward. She was mentored I'm so sorry. She was mentored by Dr. Kshitij Rezada, who has completed his MBBS and MS as well as his fellowship in vitretina. Is currently a vitretina UV and ROP specialist at the Raizadeh Eye Clinic in Bareilly, UP. So, like Niranjan had said, in these journal clubs, we usually club and group a young mentee with a mentor to understand the journal club topic, which is discussed during the monthly journal club. Dr. Kshitij completed his fellowship in vitretina, ROP, and UVA from Prakash Netra Kendra, Lucknow. Followed here, his career highlights include a second prize in the EVRist in Budapest in November 24 in the category of Best Surgical Video. He was also awarded an International Ophthalmic Hero of India Award by AIOC at Yashobhumi, New Delhi this year. He is also an active participant at ASRS, EVRS, and other national and international conferences, as well as several PubMed index journals and publications, including textbook chapters. He has developed an animated explainer videos for ophthalmology postgraduates, fellows, and young practitioners, as well as an animated explainer video, which is available on YouTube, Instagram, Facebook channels of iSpy. With that, I'd like to invite Dr. Ritika to please present the journal article. Dr. Ritika, you can share your screen. Are you there?
Yes, sir.
Yes.
Is the screen visible?
Yes, you can just put it in full screen. Yeah, you can start.
A very happy Doctor's Day to everyone. On this auspicious day, I, Dr. Ritika Khandelwal, PGT1 from AIMS Kalyani, I'm going to present the YOSI Journal Club on the topic Insights into the Cataract Surgery Outcomes in the Age-Related Macular Degeneration, Perspectives across the severity grades and the clinical routine conditions. The mentor for today is Dr. Kshitij Rezada. Let's begin with the discussion. The objectives of the study were whether the cataract surgery leads under the real world conditions to measurable effects on best corrected visual acuity despite the AMD related damage to the macula. Also, whether the cataract surgery changes the need for the intravitreal injections in the subjects with neovascular age related macular degeneration. The introduction goes the cataract and the ARMD both lead to the decrease in the visual acuity, and there is increased coincidence of both because of age being the common risk factor. Both the age-related eye disease study cohorts suggest that the AMD patients with the cataract benefit from the cataract surgery. The materials and methods describe the study design as retrospective monocentric real-world study. The study period was between July 2018 and September 2023. The study setting was done at Charlotte campus, Benjamin Franklin, and the study population included the dry AMD patients or the neovascular AMD patients undergoing the cataract surgery. The total number of patients were 418, of which neovascular AMD patients were 85 and the dry AMD were 333. The selection criteria included the inclusion criteria as age more than 50 years, the dry AMD cohort with the 2 months follow-up after the surgery, a neovascular AMD cohort with 6 months follow-up and more than equal to 3 intravitreal injections with same VEGF inhibitors before the cataract surgery. If both eyes were eligible, the eye with a longer follow-up after the cataract surgery was included. The exclusion criteria were missing signs of AMD in the OCT, a combined phaco-vitrectomy or previous vitrectomy, choroidal melanoma, and the previous intraocular infection or previous retinal detachment. Subjects with the diagnosis other than the AMD that require intravitreal anti-VEGF treatment. The data collection, the patient demographics, pertinent past ocular history, prior ocular surgery, intravitreal injections, clinical examination findings, and the OCT scans were evaluated for each visit as available. The main analysis was focused on the functional and the anatomical outcomes at 2, 6, 12, 18, 24, 30, and 36 months follow-up respectively. The primary endpoint was the change in the best corrected visual acuity. The secondary endpoints were anti-VEGF treatment interval and the OCT parameters. The OCT parameters included presence or the absence of macular edema, intraretinal, subretinal fluid, and the pigment epithelial detachment. The cataract surgery and the intravitreal anti-VEGF treatment. The cataract surgery was conducted by two equally precise surgeons. Phacoemulsification was performed under topical anesthesia with monofocal ultraviolet filtering, single-piece intraocular lenses implanted into the capsular bag. In neovascular AMD, the individual intravitreal anti-VEGF medications like bevacizumab, epiversib, ranibizumab was injected during the cataract surgery in 62% of the cases. Efilbercept, bevacizumab, ranibizumab, brolucizumab, and faricimab were the anti-VEGF medications used. Main outcomes were primary, post-op best corrective visual acuity, and the secondary outcomes were post-op central retinal thickness, macular volume, difference in the qualitative OCT parameters, alteration in the anti-VEGF intervals, therapy interval, and the post-op complication. Temporary post-op increase in the central retinal thickness and the macular volume were observed, but they reverted back to the pre-op levels by 6 months after the surgery. The statistics, unless specified otherwise, data are measured as mean plus minus standard deviation, and the means of the best corrected visual acuity at the baseline were compared with the follow-up visits using a Wilcoxon signed rank test to account for the non-Gaussian distribution. A p-value less than 0.05 was considered significant. Descriptive statistics were computed using the Microsoft Excel version 16.15 Microsoft. Statistical analysis were carried out using the statistical packages for social sciences version 35. The recruitment process was done from the Berlin Macular Registry, considering 3,438 patients undergoing cataract surgery from 2018 to 2023, of which 2,854 were excluded because of the aforementioned exclusion criteria, namely no signs of AMD in the OCT in 2,244 patients. There were combined phagovitrectomy or previous vitrectomy in 123, and the choroidal melanoma was there in 98 patients. Of the remaining patients, the cataract surgery procedures with the concomitant AMD was found in 973 patients, and 389 were excluded because of the because they had bilateral procedures, of which only one eye was supposed to be taken, which had longer follow-up time. Of them, 584 were taken into consideration, of which 166 were also excluded because of the aforementioned exclusion criteria. And finally, we got 418 eyes, of which dry AMD were 333 and neovascular AMD patients were 85. The results showed that there was significant improvement in the best corrective visual acuity from 0.69 plus minus 0.45 baseline to 0.46 plus minus 0.38 up to the final visit. There was also seen that the central retinal thickness and the macular volume increased after 2 months after the surgery, but they reverted back to the pre-op levels in case of neovascular as well as in the dry AMD to the pre-op levels after 6 months of surgery. In case of the dry AMD, we see that in early AMD, there is more visual gains in after the post-op as compared to the late post-op changes in case of the best corrected visual acuity. The baseline characteristics were the number of the eyes included in case of the neovascular AMD 85, in dry 333. Other parameters were the eye, right or the left one, the male and the female, the age, which was mainly because AMD is more than equal to 55 years of age. So here our ages has been mentioned. The total treatment time, follow-up after the cataract surgery, best corrected visual acuity, IOP, central retinal thickness, and the macular volume respectively. The graph is showing how the best corrected visual acuity is being improved after the post-op. The x-axis shows the BCVA at the baseline, and the y-axis shows the BCPA at 2 months and final visits of the follow-up. The diagonal line is representing that the values below the diagonal line are showing the increase in the visual acuity. Hence, we can say how the visual acuity is better at the final visit. Similarly, we are seeing the same changes in case of the dry AMD. In this, we can also interpret from these graphs that how early AMD below the line the visual gains, and in the late AMD below the visual line are shown. Like in the below the diagonal line, the visual gains in case of early AMD is more as compared to the visual gains in case of the late AMD, as we discussed earlier. The dry AMD subgroup analysis, early AMD presents of more than one rose of 63 to 125 micron in diameter, mid AMD more than equal to one rose of more than 125 microns in diameter, and late AMD geographic atrophy with 3000 micron around the fovea, fibrosis, or both, as told by ma'am earlier in her presentation. Conversion of the dry AMD, 16 individuals with the AMD transition to a long-term or even a permanent non-exudative state after being previously treated with 22.0 plus minus 21.6 intravitreal injections for neovascular AMD. After cataract surgery, 9 of these individuals maintained a macula with no signs of exudation. Improvement in the BCVA were observed at 2 months follow-up and the final visit, as mentioned earlier. The discussion of findings indicate significant benefits from the individuals meeting the study's eligibility across all AMD severity grades in terms of visual acuity after the cataract surgery. Although central retinal thickness and macular volume initially increased after the surgery, they returned to the pre-op level 6 months later. The need for the intravitreal anti-VEGF therapy remained unchanged in the individuals with the neovascular AMD after the surgery. Higher share of individuals experienced vision gains in the early AMD cohort compared with the late AMD cohort, as there is less damage to the macula as discussed. Even in the subjects with the neovascular lesions, geography, atrophy, or fibrosis, the majority experienced individual improvements. Lens opacities are functionally relevant even if the macular function is impacted by AMD. The findings of this study are in line with the literature. In both the AREDS cohorts, it could be shown that the vast majority of the AMD subjects respond to the cataract surgery by vision gains. Individuals with the AMD of all severity grades showed a temporary increase in the central retinal thickness and the macular volume after cataract surgery. This observation is in line with the Beaver-Dunn eye study that investigated changes in the retinal thickness after the cataract surgery in a population-based cohort. The need for intravitreal anti-VEGF therapy did not change after the surgery. It was, on average, one injection every 8 to 9 weeks before and after the surgery. Limitations inherent to the secondary data collection of the real-world data, treatment is not guided by the pre-established protocol, and there was bias in the selection of the patients as they are considered to be suitable for cataract surgery by their doctors. Conclusion: transient increase in the retinal thickness and the macular volume return to the baseline within 6 months after the surgery. Individuals with the AMD have achieved a long-term or permanent non-exudative state after the treatment for neovascular AMD, and overall the study suggests no adverse long-term macular changes attributable to the cataract surgery. Let's end the discussion with Mary's step-by-step approach. The method, the design, the retrospective monocentric real-world study conducted by the Charlotte Berlin. The data source, Berlin Macular Registry, included the posterior chamber phacoemulsification cataract surgeries in the patient with either the dry or the neovascular AMD. Follow-up mean time was of 18.8 months, the range being 2 to 62 months. Comment: solid for evaluating routine clinical outcomes, although retrospective designs limits the casual interpretation. The hypothesis was well defined, the sample size was large, and the study population was mainly European with a well-defined inclusion and exclusion criteria and a well-defined study period. Assignment shows cohorts with the two groups of dry and the neovascular AMD, the allocation showing no randomization, assignment based on the disease subtype. Baseline comparable groups separated by the AMD activity. However, potential selection bias exists due to the retrospective nature. The assessment showing the outcomes, the primary being best corrected visual acuity in logMAR and pre and post operatively. The secondary outcomes being the central retinal thickness, macular volume, qualitative OCT parameters, and anti-VEGF injection frequency and complications. The measurement of the OCT and the BCVA are industry standard for AMD, anti-VEGF therapy, tracking reliable and blinding not reported, likely none due to the real-world context. The results being the visual acuity. The neovascular AMD mean BCVA improved from 0.69 to 0.47 logMAR at 2 months and remained approximately 0.46 at mean follow-up time. In the dry AMD, improvement was from 0.53 plus minus 0.47 to 0.27, sustained to 0.06 at the final visit. Retinal morphology, the CRT and the macular volume increased transiently, and they return back to normal by 6 months of post-operative period. Anti-VEGF burden, no significant change in the injection frequency post-surgery for the neovascular AMD, and the complication not detailed in abstract, presumably low given during the surgical context. Interpretation. The cataract surgery significantly improves the best corrected visual acuity in both the dry and the neovascular AMD without the long-term detrimental effects on the macular anatomy or treatment burden. The authors appropriately highlighted the transient post-op changes and note the stability of the anti-VEGF therapy demand. The limitations were that it's retrospective, single-center, potential selection bias, and lack of the detailed complication data. The extrapolation showing generalizability findings are likely applicable to similar tertiary care settings in Europe, but the caution needed in the broader context. Practice implication supports offering cataract surgery to the patients with AMD, even those receiving anti-VEGF treatments, as it improves the acuity without worsening the disease course. The future directions, prospective multicentric trials would strengthen the causal counts claims, evaluation of the patient-reported outcomes would add the depth. Thank you. I would like to conclude my presentation now. And I would like to thank Dr. Kshitij for mentoring me and YOSI Club to give me the platform to present. It was my first general club, so thank you, everyone.
Thank you so much, Dr. Ritika. I think you've done a fantastic job. It's very difficult to very lucidly sit and explain as well as break down something as complicated as statistics when it's involved, especially in cataract ARMD, because these are very otherwise dry topics and mostly values need to be extrapolated and interpreted. So from there, I'd go on to your mentor, Dr. Kshitij, and then I would introduce the panel and go on to the panel. Dr. Kshitij, can you just give us a brief idea about the article, some challenges that you faced while interpreting the article? What should young minds keep in mind when they are interpreting an article like this, and how to mainly apply it in clinical practice?
Yeah, thank you, Anujit, and I would like to thank YOSI for giving this opportunity. I would like to congratulate Dr. Ritika for putting up our show, and she has been very inquisitive over the last 2 weeks and very diligent in inculcating all the changes that we discussed as far as preparing this presentation for JC is concerned. So regarding the insights into this article, so despite its limitations, this study has a robust real world data, and the results that it has come up with are in sync with the existing literature. More importantly, the results are clinically relevant. And this is in contrast with compared to patients who have DME and cataract. Let's suppose there is a patient who has early cataractous changes and diabetic macular edema. So it is usually advised to the patient to either stabilize the DME first and then go ahead with cataract surgery, or initiate treatment both for cataract and diabetic macular edema in conjunction. This is in contrast to patients with age-related macular degeneration and cataract, where cataract surgery at the outset is advised to the patient, because it is seen that the inflammation that the cataract surgery causes only transient increase in the central retinal thickness and macular volume of the patients with age-related macular degeneration. Even if we have a patient who has a dense PSC and with geographic atrophy, it is still prudent to operate cataract because post-operatively, even if the BCVA doesn't go up much, but the patient is likely to report that he has symptomatic improvement because the overall amount of light that is entering his eyes after the cataract surgery increases. And remember that in age-related macular degeneration, rest of the retina is healthy. Apart from macula, rest of the retina is healthy. So the overall amount of light that the patient perceives makes him more ambulatory and makes it easier for him to go ahead with day-to-day activities. I would like to give it over to the panelists to go up with the further dissection of this paper and throw more light for the viewers to perceive the data of this article.
Thank you, Dr. Kshitij. I'll just go ahead and introduce the panel so that we can have a small discussion regarding the paper and what can be done. So it gives me great pleasure to introduce Dr. Orkoprava Pradhan, who is an associate consultant at Department of Vitreoretina in Shankar Nethralaya, Chennai. He has completed his MSDO, DNB, MRCS, FICO, FMRF, as well as FAICO in Vitreoretina. He has over 20 publications with peer-reviewed journals and written 9 book chapters, among which he has also amassed an accolade, the G. Venkataswamy Gold Medal for securing the highest marks in his DNB final examination. He is also gold medalist in DO final exam and won the IGO Merit Award in 2023, as well as been an Erudio quiz finalist twice in a row and got distinction in FICO final exams. Our second panelist is Dr. Srijita Mitra, who is currently the Director and Chief Vitreoretinal Consultant at Kasturi Medical Center in Kolkata. She's a specialist in ROP services and phaco-refractive associated with multiple hospitals as a VR visiting surgeon in Greater Calcutta. Beyond ophthalmology, she is the author and founder at Mitra Lok Charitable Trust in Kolkata. Uh, our third panelist, Dr. Bhavik Panchal. He is a diplomate from the National Board of Ophthalmology, followed by his fellowship in Vitreoretina UVA from LVPI Hyderabad. He has over 50 peer-reviewed publications and numerous awards in multiple years, which I will not go through. We all know Bhavik sir very well in YOSI Journal Club. He's been with us for a very long time. He has also held positions as an IGO sub-editor, as well as an executive member of YOSI, as well as the head of the Vizag campus of LVPI. Our next panelist is Dr. Samir Chaudhary, who's currently a consultant at Arvindai Hospital, Madurai, and currently an executive member of YOSI. He's completed his MS from Arvindai, as well as currently an executive member. He's completed his FICO exams with over 25 peer-reviewed publications and 3 book chapters. During this very short time, he has also completed 4,000 cataract surgeries and is one of the youngest surgeons to perform life surgery, at least to the best of my knowledge. He is the PG orientation in charge for 2021 and 22, training over 40 residents. And once again, he has amassed numerous awards during this time, which I will not go through at this time. Our next panelist is Dr. Ashish Markand, who is an assistant professor in the Department of Vitreoretina ROP and UV at RP Center, New Delhi. He has completed his MD, MCH, FRCS, FICO in UVA as well as in Vitreoretina and as well as his DNB. He has 65 scientific publications and numerous international grants. He also has a number of awards to his accolades and is currently an executive member at YOSI with a very popular Instagram channel called Your Retina Doctor with over 130K followers. Our next panelist is Dr. Aditya Varman, who's a cataract and refractive surgeon at Uma Eye Clinic, Chennai. He has completed his MBBS, MS, FWCRS, FAICO in cataract and phaco. He has performed over 3,000 cataract surgeries with numerous premium IOLs as well as 2000 smile procedures and 300 ICL procedures. He has recently started performing presbyon for presbyopia correction, and he is the head of the phaco training program at Eye Clinic. He also has numerous awards, some of which include the best paper at ACRS annual meetings, this Professor C.P. Gupta Gold Medal, as well as the overall best paper at TNOA meetings 3 times in a row. He's also a live cataract surgery presenter at National Ophthalmologic conferences among one of the youngest at the age of 28. He is also an executive member at YOSI. So with that, I would like to just go on to the panel, and I would like to start with Dr. Srijita. And can you give us some insight as to, in your clinical practice, when you face a patient with AMD, what the current literature tells you, and how would you advise young ophthalmologists, those who have just passed their MS, to tackle cases like this? So a very interesting looking OCT retina, OCT macula with cataract.
Yeah, hi Umjit. Yeah, in my practice, of course, however this article has suggested that, especially in dry AMD cases, the patient definitely benefits when the patient has geographic atrophy and such findings in OCT. So removing the cataract will definitely help the patient. And in wet AMD cases also, of course, there's a direct correlation that there is a vision improvement in cataract surgery, post cataract surgery. However, in this article, which I have found, there is a selection bias because the patients have been treated on various anti-VEGF molecules, not a particular one that you can compare the CRT and the MV post operatively. Correct me if I'm wrong.
Please go on. I will get the opinion from the panel as well.
Yeah, so the CRT and the MV that is mentioned in this article, can it be compared since different
Yes, this
cocktails of
is
anti-VEGF has been
um, confounding factor because they haven't stuck to one anti-VEGF molecule. In fact, they have used bevacizumab, ranibizumab, aflibercept, brolucizumab, and even faricimab for treating patients with neovascular AMD. So this is definitely a limitation. It's a confounding factor.
Right.
yeah. So
Dr. Ashish, can I have your opinion on this? Your opinion on the article as well as what you are doing in your clinical practice?
Yeah, so a very nice presentation, but I feel that in patients of AMD, in dry AMD, it is a no-brainer. We know that if a patient has geographic atrophy or there are some drusions, definitely the patient will improve vision and the progression. Obviously, AREDS has also shown that over a period of 10 years, there's unlikely the progression of dry AMD which happens. But the problem comes with wet AMD. You see now, the article says that though there was an immediate increase in the central macular thickness, but probably after 6 months it came back to normal. I probably feel the follow-up period is very less as far as the study is concerned. When we treat these patients of wet AMD, I preferably prefer that at least 3 loading doses have been given to the patient before planning for a cataract surgery. That is one thing. Second, I also plan an intravitreal injection along with the cataract surgery because the fluidics or the dynamics or the inflammation which happens, we have seen personally that some of these patients, they tend to increase, the pathology in the posterior segment tends to increase, and so it is always wiser that we give an injection. And as rightly pointed out, that the anti-VEGF injection which was planned in the study, because it is a retrospective analysis, so they have tried to pull up everything just to increase the number of patients. But that is one of the very major limitations, that the injection which is being given is not fixed. So either they've given bevacizumab or Avastin or Lucentis, something like that. So that is another limitation of the study. One point which I again wanted to highlight is that in the study they showed that about 65% of the patients of wet AMD, that about there were 83 patients, but only 65% of them they received injections and less 35 they were not. I think the study should have actually clarified why few of these patients were not given injections, why few of them were given, and there should be a subgroup analysis of the patients who were given injections versus who were not given injections. I think that would have been a better way to actually look at the progression of the disease, if it was happening or not. Also, in the conclusion, the speaker told that the anti-VEGF burden it did not change after the cataract surgery in cases of wet AMD. Exactly how did they actually calculate it? That again is not clear. That how was the anti-VEGF burden calculated? Did they actually compare it with the group where the patients are not given an anti-VEGF injection? But my personal take is, if a patient comes with wet AMD, the threshold of giving an anti-VEGF injection with cataract surgery should be very low. We should preferably give it, and patients should always be counseled that during the immediate post-operative period, preferably in the next 6 months, the likelihood of AMD, the wet AMD being increased, the progression of the AMD is could be there, and he might require more number of injections. So that is what we do in our clinical practice. For dry AMD, I feel it is a no-brainer. We can directly go ahead with cataract surgery because the likelihood of conversion from dry AMD to wet AMD is very rarely seen after cataract surgery. Not maybe next 5 years, I feel. But for wet AMD, it is a slight tricky situation.
Thank you so much, Ashish sir. A word from Dr. Orkoprova Pradhan sir. So, what just a 2 cents on your take on the article, as well as Dr. Ashish mentioned something about going for 3 loading doses for patients who he wants to take up for cataract surgery. Do you also practice 3 loading doses? I would also ask the remaining panel that question.
Yeah. So actually, it depends upon the significance of means the grade of cataract. If it is like significant cataract along with wet RMD or wet RMD, so in that cases we do cataract surgery along with anti-VEGF injection. But if this cataract is not very significant, so in this situation, sometimes the simple test, the potential PAM test, the potential acuity meter is helpful because we can tell the patient if this cataract surgery will help to improve the vision if we do the potential acuity meter test. So this is very important test in this situation. So if we see this potential acuity meter is improving the vision, so mostly this vision will improve after cataract surgery. Or if it is not, then it will not improve much. So this actually depends upon the grade of cataract. So if this cataract is not very significant, so we give anti-VEGF first and later we can do the cataract surgery. Otherwise, we give anti-VEGF injection along with cataract surgery. So yeah.
Do you go for 3 loading doses like Dr. Ashish?
Yeah, so always we give the 3 loading doses. So sometime if it's significant cataract, so we give we do cataract surgery along with the first dose itself. But if it is not a very significant cataract, so in between we can do the cataract surgery, maybe with the second dose or third dose also. Yeah, and another thing, this article doesn't mention if they have given the 3 loading doses or if they have done means as needed basis or what the protocol they have used. They didn't mention that. And another one thing in OCT also, this macular volume and the central retinal thickness, this is increased after surgery. They have told that, and though it became normal after 6 months. But the another parameter like ellipsoid zone, how is the ellipsoid zone in OCT? That was also not mentioned there. So that is also responsible for the visual outcome post cataract surgery and in the case of the ARMD management.
Right. Thank you so much, sir. Dr. Srijita, do you, just the same question to you, do you practice 3 loading doses? I know you work in a lot of high volume centers and you see a lot of these patients in the periphery as well. So
Yeah, I definitely do. But then also, as sir suggested, that if the patient has significant cataract, then yes, we'll go for cataract removal along with anti-VEGF in the first go ahead.
Right. And I would also like to get a word from Dr. Samir. So he's in Arvind, who's doing a lot of cataract surgeries. I'm sure a lot of patients are patients with also diagnosed with wet AMD. So what is the usual go-to route in Arvind and your hospital, and how do you tackle these cases?
Thank you so much, sir. A very good evening to everyone. So one thing with the study first, one thing is it's one thing that I observed was most all the cataract surgeries were phacoemulsifications. So one thing is it did not evaluate SICS, manual SICS. So SICS is a surgery which inherently is associated with more inflammation. So I don't know, it might not be very significantly different, especially when it is done by experienced hands. So I don't know whether these results can be extrapolated to an SICS surgery. That is one. Second, I would there's something which something which I would want to know in addition to this, what the study has provided is especially with the subgroup analysis of the patients where there was a decline of BCVA. One thing was what was the grade of the cataract and what was the duration of the surgery in those particular patients, because as the duration of the surgery increases, the obviously the inflammation is also going to be more. Another thing is whether there were certain OCT biomarkers in those patients which could have prognosticated poor visual acuity post-operatively. And practically speaking, one important thing in AMD is the choice of IOL. So in such patients, we should definitely, avoid multifocals and EDOFs, as they are going to further reduce the contrast sensitivity, which is already compromised. So it's always safer and better to choose for a monofocal IOL in such patients.
Right. Thank you so much, Samir. Dr. Aditya, sir, are you there?
Yeah. So,
Am I?
so I'm not a retina person, so I'll just give you my 2 cents in the perspective of a cataract surgeon. So, yeah, can you hear me now?
Yes, yes, please go ahead.
Can you hear me now?
Yes, please go
Yeah,
ahead.
sorry.
Yes,
So
sir.
I'm not a retina person, but I'll just give you my 2 cents in the cataract surgeon now. So in our practice, so what we do is we rely more heavily on the octa. So we are able to see if very clearly if the CNVM, whether it is active, whether it's a hot or cold lesion. If we find any vascularity and we find any hot lesions, we do plan along with an anti-VEGF. That is one. As one of the other panelists also described, just doing the simple retinal cataract surgery can help you decide whether you that we do on the choice of IOL. As you know, many of these patients who have got ARMD looking at the phone or reading a book. So even if you give them a multifocal and you give them some near vision, they are quite happy with the results. So that's something that you can consider when you're treating patients with ARMD. So you can give them some functional near vision acuity so they can carry on with the day-to-day activities without relying on glasses.
Thank you, sir. Thank you for your cataract perspective to the ARMD part of it. So I'll also take this opportunity to welcome our dynamic JC in charge and joint sec of YOSI, Prasanna sir, freshly landed in India, reached Trichy. Sir, we are happy to have you with us, and your enthusiasm to be a part of every single episode of Journal Club continues to inspire us. So I would like to orient you that now it is evening here, so the jet lag is bound to be there. So before you say good morning, I just wanted to save you. So welcome, sir. We are very happy to have you with us, and just a couple of words from you before we move on to the rest of the program.
Thank you, Niranjan, for this wonderful initiative. Niranjan, Anujit, of course, Ayushi too. I think Niranjan would have oriented you guys to the Journal Club at the start, and it's been a brainchild of Dr. Sonal Kalia, and then Dr. Anujit has been a very integral part of it last year, and then myself, Dr. Niranjan, we are all actively doing a lot of journal clubs. It's been an honor to actually have you guys here, and this has been almost a 40th episode or a 45th episode in the last 3-4 years that we are doing this. And a wonderful presentation by Dr. Ritika, well monthly mentored by Dr. Siddish. We also have roped in one of a keynote speakers in the last 3-4 years, 3-4 episodes that you can see. A senior perspective by Dr. Supriya Dabir, who spoke on update on retinal imaging. And our team, especially the core, Dr. Anujit, Dr. Naranjan, and Dr. Ayushi, we are trying to work on more cross pollination of journal clubs, which you can see usually it doesn't be unidirectional. We are trying to mix cataract with ARMD, Last time we had a glaucoma and oculoplasty. So we are trying to cross-link specialities and bring more discussion out of these kind of papers. And today we had a dynamic panel of we had Akraprava Pradhan, Dr. Srijita, Dr. Samir, Dr. Ashish, and Dr. Aditya, three of our very dynamic executives. So I think we had a wonderful scientific deliberation today. And thank you, Naranjan and Anujit, Dr. Ayushi too, for taking this wonderful initiative forward. And I'll be feeling in my duty if I don't thank our President, Dr. Devakant Mishra, and the whole YOSI Journal Club team. Yeah, back to you guys to do all the honors of the completion of this journal club. Naranjan, over to you.
Thank you, sir. Thank you so much. Once again, thank you for being with us today evening. And I think, Anujit, shall
I
we
have
move to
I have one
the
question for the monthly mentor, and maybe some panelists can answer it. So this is a very interesting article that can be repeated for further studying in different areas with different anti-VEGFs with different conditions, because both conditions, both dry and wet AMD, are pretty prevalent. So, Dr. Sitij, just a question: if there are young ophthalmologists listening, they would want to replicate a similar study to see what the results are. What are the changes that maybe you would do to this article if you would want to do a similar study, if a postgraduate would want to take up a similar study going forward? Because as a journal club, we must instill in them the right ways of conducting a study as well as executing something like this. And since this is a very doable study for postgraduates in their institutions, your 2 cents, and then maybe we'll conclude with the panel if they would like to add anything. Dr. Kshitij, are you there? I think we have, I think he's having some connectivity issues. So I'll move on to Dr. Srijita and Dr. Orko Provo. So Dr. Srijita, anything that you would make changes if you were conducting a similar study, or any tips for postgraduates in this regard?
As you suggested, yes, it's pretty much doable, but yes, we have to cut down on the streamline it better. Like we choose maybe two anti-VEGF and compare the molecules. So that can be done instead of having so many on board.
Right.
Yeah, probably a multi-center study would give more insights into it. This particular study is pertaining to patients from one particular hospital. Multi-centric study, different techniques of phacoemulsification, these could be taken into account. The cataract complications haven't really been considered in this particular study. It just briefly states that only a few subset of patients had Irving-Gass syndrome. But when the data is so large, so complications are bound to happen. So a multi-centric study would probably be more useful and throw more light as far as the progression of AMD and cataract is concerned.
Uh, Yeah, so another few things in ARMD, so not the visual acuity is the most important. So another few things like contrast sensitivity and how is the reading speed of the patient. So that's also very important. So sometimes this visual acuity can be 6/6, but those who are having like advanced ARMD, like OAD ARMD changes. So that's why, so contrast sensitivity we can include. Another one thing, OCTA, Octa. So Octa can be one good tool to include in this study. Like not only OCTA also we can include. So these are my to take up from this study.
Thank you so much. Dr. Ashish or Dr. Aditya, any last words or any comments on implementation of this study in future
Yeah,
process?
so like if I have to give a thesis to one of my candidates, I would rather do a prospective randomized study and not look at a retrospective data. That is one thing. Take up one anti-VEGF injection, and probably because we all know, like previously also I discussed that for dry AMD it does not matter much, but for wet AMD is the problem where it happens. So maybe in all these patients, we can just randomize them and then see whether giving an injection, not giving an injection, actually increases the progression during the post-operative period, and maybe try to keep a longer follow-up, maybe for a year or maybe 2 years, whatever thesis period permits. But I think 6 months is very less period, and probably randomization and prospective is one thing which would give us a better evaluation of all these things.
Dr. Samir, any last words?
As rightly told by Dr. Kshitij, like even complications, there were no complications during the study. So, like for example, a PCR where there will be, more manipulation, more inflammation, and even the inflammatory mediators might diffuse from the anterior segment to the posterior segment. Like there's a more likelihood of that happening. So probably, if we are going to do a study, so we should definitely include such cases as well.
Right. Thank you. Over to you, Niranjan.
Just
Yeah.
wanted to add a point, like if that is my take on it, that if we want to do a study in a prospective way, and if a patient has a complication during a cataract surgery, I would rather exclude that patient from the data analysis, because I actually want to look at a normal cataract surgery causing any progression in the AMD. So if something like that happens during a cataract surgery, I would rather exclude that data and would try to take up patients with an uncomplicated pseudophakia, and then looking whether it causes the progression, increase in progression or not. That is what I would do. But yeah, if somebody wants to look at the complications also, that is also a good idea to do.
Right. Thank you. Thank you so much. I think we've had a good discussion. Over to you, Niranjan. I think we can take it forward from here.
Thank you, Anujit. Thank you so much. So thank you each and everyone for such an active involvement and participation with your valuable expert comments and your suggestions and opinions. So we have a tradition of virtual e-certificate distribution at the end of every journal club session, and it's been our trademark. So now we have, yes, so is my screen visible?
Yes, it's visible.
Yes, Niranjan.
So foremost, I would like to thank Dr. Supriya Dabir Gautam ma'am for accepting to be our keynote speaker for today, and speaking so elucidely about the entire retinal imaging. So like I mentioned, it was like watching recent advances in a vintage black and white movie. So that's the way I saw the entire presentation. Thank you, ma'am. And next up, I would like to thank Dr. Ritika for accepting to be the presenter of today's article and so wonderfully, comprehensively presenting it for everybody's discussion. Then I would like to thank Dr. Kshitij for again accepting to be the monthly mentor and participating actively in guiding Dr. Ritika and also sharing his comments. Then moving on to this wonderful lineup of the panel, starting with Dr. Arkaprava Pradhan, Dr. Srijita Mitra, Dr. Samir Chaudhary, Dr. Ashish Markand, and Dr. Aditya Varman. All of them have been so kind to accept our invitation to be a part of this panel and give each and every detail to the topic and discussion. Thank you, dear all. And I would fail in my duty if I fail to thank my co-host for today, Dr. Anujit. And
Niranjan, also a few words of gratitude to you as well. I think many would not be knowing this. So this year is when we started the Journal Club sponsorships. We have our academic partner, Microlabs Vision. Thankful to Niranjan and his dynamic team of Anujit and Ayushi again, who's not with us unfortunately today. So if you guys are seeing this, so this year Journal Club is actually having an academic partner, and it's an all-inclusive journal club. And if any of you are watching this on YouTube, do get back to any one of us if you want to be on the hot seat or the panel or the presenter, or even if you are a monthly mentor. Today we had Kshitij as the monthly mentor. It is one of the most toughest jobs to be the mentor as well as the presenter, I believe. Kudos to you, do again for that. And thanks to Niranjan for bringing in the academic partner for the last 4 or 5 episodes of the JC that we are actually doing. Thank you, Niranjan.
thank you, Prasanna sir. and it definitely would not have been possible with your encouragement and lead from the front. Thank you, Prasanna sir, for being there with us in spite of your hectic and busy schedule. So with that, I would like to thank all of you, and until next episode, take care, have a good night. One small request, I kindly request all of you to switch on your videos for the headshot, which is again a customary practice we do.
Niranjan, do we have the Microlabs guy with us today? Yeah.
Yes.
Yeah.
We have Mr.
Few
Kishore,
words.
who's an NSM from Microlabs. Mr. Kishore, if you're there with us, you can share a few words.
Yeah.
Yeah, Kishore from Microlabs.
Good evening.
Yeah.
Good evening, all. So today, Mr. Abhijit cannot join the turn because he has one meeting. He has to attend one meeting in office. So today he's not there. And thanks for that, and we will continue our that association with the YOSI. And thanks, Dr. Niranjan and Dr. Prasanna, sir. Okay, thank you, sir.
Thank you, Microlabs, and a special shout out to Numerotech as well. The seamless technological thing that we are seeing with the Zoom backdrop, all the mails and all these things. Numerotech has also been a very instrumental partner for us for all this effortless background check. So thank you everybody, and I think we'll end up with a photograph as Niranjan pointed out. Yeah.
Can you do the honors of
Sure. Can everyone just turn on their cameras and make the YOSI peace sign? And 3, 2, 1. Yeah, I've taken it.
Thank you, Supriya ma'am, for staying back with us and really enlightening us on retinal imaging.
Thank you so much for having me.
Thank you, ma'am. I think we can go off live. Manjula ma'am.
Yes, doctor, once again.